On this week's Cardiology Countdown, we'll look at critical access hospitals, that is rural hospitals, and two assessments of BNP in heart failure and in AFib. So to begin with is an analysis of Medicare data over the past decade looking at rural hospitals, and sometimes known as critical access hospitals, where people in rural areas really need access to these hospitals, and whether the mortality for major conditions like acute MI, heart failure hospitalization, or pneumonia differs at all between those and hospitals in major cities. And so interestingly, what was seen is initially there was no difference, but over the past 8 years, ending in 2010, there emerged a slight increase over time at the critical access hospitals and a steady decrease in mortality at the critical hospitals in cities. And so there ended up being a difference of about 13 versus 11% mortality overall across those conditions. And interestingly, in the different cardiac and non-cardiac conditions, these trends were very similar. And so it raises the possibility that more help may be needed in these critical access hospitals. Next up is an assessment of BNP in heart failure, something we've been doing for a long time, but a very interesting analysis that was done in JACC, splitting out heart failure patients by their ejection fraction. And so what was seen is that BNP, not surprisingly, correlated with prognosis, but the levels were higher amongst those with patients with reduced ejection fraction, but when stratifying, the outcome correlated more directly with the actual BNP level than with the ejection fraction, so that if you had a BNP above 750, and this is the regular BNP, that had as equally bad prognosis for the normal and the reduced ejection fractions. So an interesting look at how the biomarker really provides strong prognostic information. And this week's number one pick is the BNP, and in this case the NT-proBNP sub-analysis done in the Aristotle trial of patients with atrial fibrillation. So here, these were outpatients with atrial fibrillation, and NT-proBNP was found to be a very good predictor of both stroke and systemic embolism, as well as mortality, with gradients ranging from 0.7 to 2 for stroke or systemic embolism, and 0.86 to 4 for mortality. And interestingly, across any of the NT-proBNP quartiles, apixaban reduced stroke, mortality, and bleeding, regardless of the BNP level, as was seen in the trial as a whole. So for this week's Cardiology Countdown, I'm Chris Cannon.